Kirti. We are able to see you well. This is Dr. Srinivas Kumar here. With me, I have Dr. Ajay, Dr. Marcelo Farank, and Ajit Mullathesari, sir. Over to you. Introduce your case and go ahead.
Thank you, Srinivas, for having me in this wonderful meeting. With me, I have Anil Dhall, who has flown from Delhi to join me to make this interesting for me in the cath lab.
Hi, Srinivas.
Ajay.
Thank you, sir. Thank you.
Hi, Ajay.
Ferenc, Srinivas, and everyone on the dais there. We're really hoping to showcase something. Good morning to you, Ferenc.
Hi, Minister.
So this is a 66-year-old gentleman who had recent classic angina, which reduced his effort tolerance. CT calcium score was more than 2,000, and echo was normal. His risk factors include hypertension and type 2 diabetes mellitus, well controlled. HB 13.6, creatinine 0.9, good counts, LDL 85 on statins, LP little a 40. Now, his coronary anatomy, can you see the angiography on the screen?
Now we don't see slides. Can you?
Not yet.
Show the, now we should
Yeah,
see.
thank you.
No, the slides are not transmitting.
Unable to project the slides for some reason from here, but I'm going to show you the angio that we've had this morning for you. So can you see the angiography now, the right coronary artery there?
Yeah, we can. Looks like a recanalized
So this is the right coronary artery. You can see. Yeah, like a you can see a small little channel there. It's a CTO. You can see moderate to severe calcification at the distal end of the occluded segment. There's a small area in the center which is missing, followed by a distal lesion just before the crux. You can see that tubular lesion, but doesn't look it could be underfilled over there. And there's a PDA and a relatively small PL branch, which is underfilled, which fills by collaterals. Now go to the left side, please. So this is our area of interest as well. So the LAD looks like a moderate lesion with a diagonal. There's a ramus which comes out, which is okay. But if you look at that circumflex, heavily calcified, gives rise to a 1 OM. Go to the next picture. You can freeze that for the moment. Can you see that? There's that small OM, and then there's a very large OM-PL branch. And there's this tight lesion in between. It's heavily calcified. And this was a little worse looking than it is on this angio. A few weeks ago, an attempt was made by towards this circumflex by an operator. And a rotational atherectomy was done using a 1.25 burr. He did a fairly aggressive echo right from rotational atherectomy from that atrial branch that you see, that ongoing, that small little branch, from that point to the lesion, but in spite of many attempts, could not cross over. Post-rotablator, he did try to get a balloon in. He got struggled to get a 2.5 balloon, but could not dilate that balloon at all. So here we have a heavily calcified lesion in a tortuous kind of a circumflex with an eccentric plaque just before a very major bifurcation, not involving either of the branches of the bifurcation. So I think this is interesting. And we plan to show you a rotational atherectomy using a differential bias and using a larger burr where I think might work. We also have a standby laser just in case that fails.
Yeah.
Anything that you'd like to ask, or any discussions?
I was just going to say, this is a little surprising, given the way it looks, but this can always happen to anybody. And I wonder, in terms of the setup, Kirti, was it radial with not a supportive guide, or what was the setup used before?
Ajay, I will confess, I was the operator, and we had to deal with these at least 3 curvatures in the circumflex. The microcatheter did not cross into the OM, so we parked it into the distal circumflex, and we had taken a 1.25 burr, and despite at least 10 to 12 runs of a 1.25 burr, we had modified the plaque so much that I thought I'd be able to deliver a balloon, but the balloon could not get a desirable result. Yeah. Possibly there is exophytic calcium there, and I realized that the right is not going to be done with that procedure, and probably needs a laser for modification to be able to open the right. So we decided to defer the procedure and come back another day.
So first of all, I mean...
So before I go further, I want to introduce...
Go ahead,
I want to
Kirti.
introduce my absolutely amazing staff. We have a very dynamic, right over there, our technicians, Ram, Dennis, we have Akash, Sagar. They are fantastic. They do all my images for me. We have Angeline, our sister in charge, who will help us orchestrate. My anesthetist, Dr. Rita Dixit, who's at the head end of the patient. Of course, my lovely colleague, Dr. Anil Dhall, has joined me. Jeenu, my scrub nurse, who's just brilliant at assisting me, who's helped me set it up. And so, go ahead.
No,
Ajay, I had interrupted you
Kirti,
before I...
really also very interesting case. Did you, I don't know, probably you don't have orbital atherectomy system available in India, but in our
No, we
cath
don't.
No, we don't have.
Okay, so I have done more than 100 such cases in last year. So this will be for me, in my cath lab, practically the first choice to try to ablate this calcified circ with orbital atherectomy to make a channel. And then the next step will be probably combination with OPN balloon or probably shockwave balloon.
Yeah, I was going to say the same thing, Kirti, because the nice thing about it is I wouldn't speed high speed through this with orbital. I would still go low. But what's nice is you can sort of get a bigger channel. But I was just going to say before we started, you know, for live case transmissions, there's a lot of pressure and all that goes into it, and it really takes a classy person to say, look, this is what I did last time. You know, I failed. We're going to try this again. Most people would never admit that, so I think it's really important for all of us to learn from our failures. And you'll see my talk later today.
We have to admit our failures.
My talk later today is 3 failures.
So I think, Ajay, it was not a failure.
Yeah, but I'm just saying,
I think it's not about the failure. It's about just being able to accept. Yes. So, we can always come back another day and improve upon our own efforts. And, this happens to me as well. And everybody in the world, I think, goes through this. But here's the story. To cut the long story short, we're going to go ahead and we plan to do the right...
So we plan this in 2 stages. We are first going to address the right coronary artery. And because the right coronary artery we felt was something which we would be better off with the laser. So we've got it all set up. And we are going to first do the laser to the right, and we had a little bit of discussion. I felt that we should use a XTR, and Kirti walked in through with a microcatheter and a run-through wire, and then placed a guidezilla for coaxiality, and now we have a 9-fiber, 0.9 fiber laser right there, and over to you, Kirti. All right, so this is where the action begins.
So typically in these right coronary arteries, I prefer to use a guide extension catheter to get me close. It keeps my laser catheter very central. It also helps me use very minimal saline flush to clear up the heme. We've got a 0.9 fiber sitting right at the proximal end of that very critical stenosis, I would say. In hindsight, I wouldn't call it a CTO at all. One could attempt this with a normal balloon, but I took this opportunity just to kind of show and showcase how an excimer laser could be used in this if required, if it was an uncrossable lesion. But, okay, so the first thing is we cleared up the contrast. So you want to give me a saline flush and we clear the existing contrast. So can you see it's very important to clear all the existing contrast in the guide. And once we do that, we are ready with a saline. We have set up our laser at 80 and 80. Are we ready?
Yeah.
Inject. Yeah, sorry.
No,
Yeah,
keep
any
going while
questions?
you work. I was just going to say, typically this use of the laser is
Yeah.
great for uncrossable lesions. And so if the balloon doesn't cross, then you would do this. Kirti mentioned he's
Inject.
doing it to sort of demonstrate the laser technique,
That's
so
right.
that's okay. Remember, laser in a de novo lesion, you have to do it safely. So he cleared the contrast because otherwise you'll get a massive explosion there. And now show how you do it. You'll basically do a nice saline flush, nice and smooth.
Clear the
forward.
contrast.
And this is the
Clear.
0.9 laser, right,
Inject,
Kirti?
inject.
It looks bigger than 0.9.
absolutely.
Is it 0.9?
It's 0.9.
It is 0.9.
And
You
it
see
usually-
that I'm actually going extremely slowly, and what we don't do in laser anymore is we don't come back. We don't pull the laser catheter back. We go and stop where we've gone and let it be. That helps us much more. And so that was your first run. It allows us at 80-80, the 0.9 allows us a 10-second run with a 5-second break. So now we're ready for our second run.
And so this is the technique you'd
You
use
can see
if
Gino
you were
setting it
unable
up.
to cross with a balloon ordinarily.
Yep.
If you can cross,
Inject.
the laser at the 0.9, even at 80-80, is not making a huge channel. So I think that's the reason he's showing it is for demonstrative purposes. Also, the guide extension helps, as he said, center it. That's what he was saying before. But it also helps because he has a JR4 guide, and it may be a little bit difficult getting through that distal cap.
Absolutely.
So we had a discussion whether we should take an AL1, but then because we were going to use guide extension
Inject
to
slowly.
keep it center, to keep the, so we decided to go ahead with a Judkins style.
And typically, what you see is the second operator, as you're going forward, is injecting saline to cool everything down. If you stay on the same area for a long period of time, you want to move the wire back and forth a little bit. Otherwise, sometimes the laser can actually melt on the wire.
Yeah.
Kirti, have you seen that?
So we haven't seen that because we're moving the wires all the time. We don't keep the same wire at that level. And you saw I manipulated my guide as well, repositioned my guidezilla. And all this is very important because the laser emits a huge amount of energy at that tip, you know. Though it's only 50 microns, but it's quite intense. Okay, let's go. Clear.
And you have to be careful. You're watching the STs. You want to make sure that there's no, cavitation and embolization that way. If that happens, then you need to give it a rest. So those are the things to watch with laser.
Before the procedure,
So it looks like that distal cap is a little resistant.
Yes, it is, and we won't have an issue with going with a little bit of contrast later on, but I would be very careful. Sometimes you don't really need to cross it. You do enough alteration of that plaque, but you know that laser doesn't go through calcium. Okay, go inject.
So Kirti, since you're not injecting dye much, how do you sense that there's a perf in this vessel?
Yeah, that's a good
There'll
question.
be chest pain, there'll be drop in pressure, there'll be change in hemodynamics. I just don't use any contrast at all because it doesn't help. I got a good pressure. I'm okay.
Yeah,
And as long as we use only saline and we have a guidezilla, I think we're okay. The problem happens when we have contrast.
Yeah, I would highly recommend against using contrast unless you're in stent. And even then, with Shockwave now, the use of laser with contrast, for us at least, has gone way down. It's just a super uncontrolled way of causing a burst in the vessel. But it looks like you've crossed.
Ready? Yeah, just a little 1 millimeter. Yeah, go ahead. You have to be extremely patient. You should not rush. Take all the time that you have. And I think it's amazing because what we've seen is that after the laser, most of the times, our IVUS catheter will just fly through.
Yeah, we have.
Show me the angio
sometimes
before
we see
and
that,
see if I've gone.
but oftentimes, especially for proximal caps, we still have to do further modification work and sometimes even atherectomy
A little balloon,
in CTOs, but it just depends on the type of case.
Just turn that there, put that there, and see where my laser is.
I think you're just at that tip, distal. Yeah.
we're just at the distal cap.
Just making sure that I'm absolutely certain.
Yeah.
Yeah, ready? Just one more.
Yeah.
Yeah, inject.
When he said inject, he meant saline.
I think we're gone for head.
Cross.
Yeah.
Yeah.
Yeah, I think
Yeah,
you're
okay.
in reasonable
That's
shape
it.
there.
Yeah, in reasonable shape. I'm going to take this out. Give me my IVUS catheter.
So in a balloon uncrossable situation, the advantage of the laser is you can use your own wire and take the laser. So typically you'll try, 1.5 balloon microcatheter. You might try even, rupturing the balloon. But once that fails, in the old days, all you could do is shove the microcatheter in and wedge it and swap for a rota or an orbital wire. This case, if you try laser, then it can cross in that circumstance.
Could you make maybe some comment according calcified lesions? So sometimes if you have CTO case, you cross with a, let's say, fielder or sometimes Gaia, and no balloon crossing is possible. No microcatheter can cross, no smallest balloon can cross. So then would you try to go through with a laser, also in very, very calcified CTO?
Yeah, and so in my practice, that's what I would do next. And then if that fails, sometimes it's going to fail. And if that fails, then you start doing things like going subintimal or external cap crush or other things like that. But there's no downside to trying it there. And in this case, I suspect, Kirti, you're going to find that you're able to dilate much, much easier now that you've done this.
Much better. Yeah, that's what we expected.
So, we have two choices in that situation. I use the laser, but at some times I've also used the Tornus device. And I think the Tornus works in that for me as well. But the laser has actually made it very simple and easy. You can see we've got a distinct channel now through which I think my IVUS is going to just fly through. So give me the IVUS catheter, please.
Yeah, the laser is not reproducible to work, 80% of the time in that scenario that we're talking about, but it sometimes works. And so if it works, then it made your case a lot more simple.
So once the wire crosses, previously we used to actually use a huge amount of balloons and tornuses and things like that to kind of cross a lesion or cross another device in a micro catheter uncrossable lesion. But after having the laser in our cath lab, the time that it took us from crossing the wire to the first dilatation, in the few cases that we've done, seems much lower than the previous times. Is that your experience as well, Ajay?
So here
I don't want to sound too skeptical, but I'll say that it's like anything that you try the first few times, you're like, wow, this thing really works well, and then you start experiencing failures, and then, it's sort of a return back to reality. So, but I still think it's worth trying, and I think that it can be useful. Obviously, this is probably going to need to be dilated more, and one thing with IVUS catheters is...
So for me, if this is not going, I might change it for a rota wire and do a rotational atherectomy.
Yeah, I think the distal part is still a little difficult for you to get across. I think it's better to change to
That's
rota.
heavily calcified. That's heavily calcified. Yeah.
Just get a rota in and ablate that area.
Yeah. And this is, again, I mean, I know Miroslav said it before.
Show me the IVUS.
For those of us that have orbital, it's really nice because basically the wire is really nice, and you can do it through a 6 French guide extension as well. So you really don't have to switch your setup.
Are you able to see the IVUS?
Yeah, we can see it.
Can you see the IVUS?
It's really calcium? Not sure.
So we have not crossed. We have not crossed the calcified area.
The
The calcium is beyond this. So this is the proximal part of the artery. You can just sizing it up. Fairly large artery, around almost 3.5 millimeters proximally.
It's amazing that
You can see that calcium shelf on the...
Yeah, it's really just that distal cap that's heavily calcified at the bend.
I think one option will be to take now a small low profile and see balloon, sapphire, something like this, and try 1.5, try to open, and then let's see.
Stop.
Yeah, because for efficiency, Kirti, if you're able to open it with something, you already have your guide extension, then you probably can do lithotripsy, and you may just be able to proceed. But it's up to you, obviously.
So that's not the algorithm I follow. What I do is if I have an uncrossable lesion at this stage, I will use a rotational atherectomy because it's more cost effective for me, and it is very likely to make everything work after that without using highly expensive technology.
I fully agree.
So we've already used the laser to demonstrate it. And my routine cases, if the iris didn't cross, for me, it's, I have to get a rota wire. Yeah, it's an indication for rotational atherectomy.
Yeah, makes total sense.
So give me a microcatheter, please, and give me a pacing wire.
Kirti, just
You
being
take
a
this away.
devil's advocate, would you have taken a rotablator as the first option, not the laser in this case, retrospectively?
Absolutely, because we would have to use a rotational atherectomy for the circumflex, but I only use laser to show how it is used, and just to demonstrate that this is how we could use it when in a difficult situation. But I think a first choice rotablator would have been a great choice there.
Yeah, no, I think as you said before, that part of this was to demonstrate, what goes on. I think for most of us, the algorithm is, balloon uncrossable, you have a wire down, then swap it out for atherectomy, do rota or CSI, and then proceed. If the balloon doesn't even cross, then you go to laser, obviously, and do it that way. So that's the teaching point. But it's a very good demonstration because not everybody gets to see this very often. So Kirti, why don't you, while you set up, are you set up to go? Because we'll stay with you real quick, and then we'll go back, and then come back.
Typically, it'll take me 2 minutes to set up, but please feel free to go back and we can show you later because we wanted to show this. We can show you rotational atherectomy in this artery or in the circ, wherever you choose to.
Yeah, why don't we do that?
Watch.
So we'll go back, and then we'll love to see your technique for the circumflex. That would be good. I think you're wise in putting the pacemaker in because you're going to be doing both the right and likely the circ as well. There are many people who say they never use it.
Yeah.
But this is a reasonable case to do it. So let's go back and then
we'll come back.
Kirti, we are back with you.
And that's a bigger burr.
Perfect.
Hello, are you able to hear us?
Yeah. So that's a 1.5.
Is it? Oh, so I'm just magged up.
1.5.
We're magged up more than.
No, we're not. We're just normal mag. And,
no, for what I'm used to. I tend to work on that.
Yeah, okay. Yeah.
Now, so Kirti, what speeds are you using for your burrs?
So we started with 180,000.
80,000, I go up to 200,000.
Same with you. 200 here. Ajit, what are you using?
I would use around 180 to 200.
It's interesting. There's Japanese studies showing that you can go slower, but I think there's now a movement to go, much higher, and many people are just starting at at least 160 and up to 180 and beyond.
So Ajay,
go ahead.
So Ajay, we started with 150, 160, and we used to take forever to cross.
Yeah.
So we go to 200,000 typically in our cath lab and go cross. And once we made our first cross, then we come back to 120 and do a very gentle run a couple of times. And I think if it adds any value, that's the time it'll add the value.
So the Japanese study actually shows that the debulking is better at slower speeds, but the crossability, you probably still need to have a higher speed.
Yeah, I think that's everybody's experience too, is that you sometimes have to go very high to cross.
120,000?
Now we think we have crossed, so we have slowed
Now we're going to
down.
do 120,000 run on the same, waiting for, so our pacing wire, you saw that it's going on to pacing. Blood pressures are perfect, patient stable, no ECG changes. Bradycardia is a problem sometimes in the right, so we expected that.
Especially when there's a circumflex disease.
Can we see the hemodynamic
so
screen?
120,000?
Yeah,
please, can you show them the hemodynamic screen, please?
Right now, it's all perfect,
Ajay, actually, there is a newer version, RotaPro. You start using it because hand-leg coordination is a problem. So RotaPro has just a button, you press it and then you keep moving the burr. So it's slightly more user-friendly, but if you make it too expensive, it doesn't work, I told. So they have come down on the price now in the country too.
Yeah, that's good.
So
No, for us, they just increased the price and took the old one off the market. So you see pacing there.
So that's 120,000?
Yeah. But see, I think it's a good demonstration because, I don't know. There are a lot of people who never use pacer with Rota, or they claim they never use it. And then you ask them more aggressively and they say, I only use it when the patient gets asystolic, which means that you need to use it.
So there is this movement about right coronary artery rotas with aminophylline 250 milligrams. But in our experience, I think we are
So,
much safer with a pacer.
Maybe
So I think,
just
Ajay, the problem is, why would you want to
Kirti.
make your life really difficult in the cath lab, right?
Kitty, maybe
Yep. Hi.
maybe I can just tell you some important story from our cath lab. So we are high volume center in Germany, and we performed around 200 rota cases a year. So I do a minimum 100 cases per year. And in last 3 years, I had this year, I think 5 weeks back, I had a gentleman with similar right coronary artery as now shown from Mumbai. And it was really asystole. So we stopped the procedure. It was necessary to put a pacemaker to continue to approach the rota case. And this was from more than 300 cases, only one case.
Yeah.
Where
Kirti,
definitely needed pacemaker.
so you can't see him as much, but he basically did the single operator right there to take it out by himself.
That's right. That's right. Kirti doesn't like a second
So,
operator
I don't have Anil in my cath lab every day, and I'm so used to just being by myself and my nurse. So she comes behind me, holds the valve open, and we just do it.
Yeah.
Makes it easier for us. We're so used to it.
So
But to answer Ferenc's question, Ferenc, if you're working in an institute which has 5 people in there any time to rub into you and join you in the cath lab in case there was trouble, that's great. But I work in a solo private practice, and I'm often the single operator. So sometimes it's okay for me to just put a pacing wire, even if I think it may not be necessary, to just make my life easy and not have an event which prompts me to do it.
Come, let's.
yeah, I agree. There's also some
just a minute.
there are ways you can rig a pacing setup to the rotowire itself, so you can pace over the rotowire if you need to. But for now, this is a reasonable way of doing it as a whole.
The question is, how is the flow now? Do you have some slow flow or?
Yeah, we have got we
No, we don't have any slow flow.
Looks
Oh,
pretty
it
good.
You see that?
Nice. It looks, so we have at least now small channel. I think you can go ahead with
No, I'm going to remove. Give me a
Give me the
run-through wire.
microcatheter.
IVUS
Give me a run-through
to
wire.
see if you need
Yes, we are going to do an IVUS,
some
yes.
additional steps for preparation like shockwave or whatever. There is one more distal lesion which probably you have to also to treat.
I was thinking to leave that alone. What does everybody think?
Can we see some different another
I
projection?
think it's gonna. I mean, you could leave
Focus
it,
your
but-
attention to the proximal lesion.
But I think it's
Yeah, let me just sort out the proximal.
Anyway, you have an IVIS.
Both Anil and I felt that it wasn't very critical.
Yeah, but we have an IVUS, and we are going
you
to
can
just
have a look at
actually
what's
see
happening distally.
what
with
is the
IVIS.
yeah but at the same time, what we our pre-procedural estimation was that we were going to leave the distal.
Yeah, I don't blame you. I would be thinking the same way, but my sense is that it's not going to look great at the end. But that there's always it's okay.
That's true.
It's
So
funny.
my question is, it's when you finish with the proximal circumflex, would you rely on an IVUS or would you rely on an FFR to kind of fix that?
The right?
I wouldn't rely on IVUS because IVUS would be difficult and it will show me a very squeezed. My IVUS catheter will actually occlude that lumen to a large extent.
Yeah. The only thing you worry about is it's the outflow of your stent, and there's not a lot of branches in between. But I suspect that stent will stay open even with the distal lesion. But with better filling of the vessel, it's going to look more tight. Srinivas was mentioning the Rota Pro versus the Rota, and I can tell a very funny Paul Tierstein story. He said when they got the Rota Pro, he liked it. It was very easy because you could use your hand. but he couldn't figure out what to do with his right foot and how to put the foot on the table.
What to do with this? So you know, most of us dogs will do the same thing. But it's interesting that I've not used the Rotor Pro, so I really am waiting for all your experiences. I've not used a single Rotor Pro yet.
But Kirti, recently we used in one of the patients. I felt it is slightly better, comfortable, but if they make it too expensive, I don't think it is that worth
And
the
they
cost.
actually had to modify it. We were talking
So
about
then it doesn't remain so comfortable, does it?
they had to modify it because it was a
So
pain to
remember,
do
when
the
you're
Donnybrook.
using an IVUS catheter, it's... So Ajay, this is something else that I've learned in these calcified RCAs is sometimes just keep a sustained pressure on that IVUS catheter and it'll keep going forward a little bit rather than trying to push it.
Yep.
And makes your life easy. You can see that IVUS catheter just progressing.
It's just moving slowly.
It's just moving slowly with every beat.
Yep. But don't over push because
Okay.
you know for other people when you shove too hard the
No,
imaging
don't push.
catheter,
Exactly.
you'll kink it
Exactly.
and then it gets stuck and then it's a disaster.
The other problem with the Rotor Pro is that the sound is not as familiar as what you hear with the leg
Get the
road
IVUS.
ablation. The sound
Get the IVUS here.
is different.
It's there.
Yeah,
They're
that's
seeing
great.
it.
You get used to it though. It's okay.
So you can see the IVUS now.
So Ajay, if you're very, very comfortable with a traditional rotational atherectomy, would it add value to your lab to have a Rotor Pro?
No, and we told them not to bring it in for that reason. And they got mad at us.
Okay.
And then what they didn't, and actually, you know, there you go. There's that one area.
Look at that calcium
Look at
there.
this. Look at this. This
But
is
if
the
they
one
just
area.
replace the old one with the new one, it's welcome, not charging without much.
Yeah, but they don't do that. So what they did in the United States is that they basically discontinued the old one. And in fact, I'm very upset that you can still get it here
sad.
because they told us that they weren't making it at all. But the fact that you can get it here suggests that that's a lie. but basically, they discontinued the old
you
one.
can
You only have
actually-
the new one. It's good though. I like it. It's more convenient.
So, Ajay, you
and
could
once I
actually-
get used to it, it's better.
Ajay, you could actually fly your patients to India for that cost and just do them in one of our labs here.
For youngsters who want to have a hands-on, we have kept both in that
Cost-effective solution.
calcium conclave workshop. You can go and practice if you want.
Stop. Stop. Hey, give me landing zones on both sides,
Yeah.
please. What are the size? I'm thinking, give me a 3.0 NC. So in my lab, the next balloon is always 1:1 size NC balloon. And here I will look for expansion or in expansion, whatever you may call it.
So
So that's the lumen measurement.
how many of you would
and there you
use
go.
another device at this stage?
So it's an underfilled lumen. The proximal is around,
Guy.
I think the distal reference is bigger. It looks here. It looks like
Yes, I think so.
I'd take a 3.0 NC.
exactly. So I'm taking
Yeah,
a
we're
3.0
taking
NC.
3.0
That's
NC.
exactly what I'm doing.
Trio.
Would you engage
Trio-
now a guideline
Trio
or
12
a
or 15
Godzilla
or
again, please? Because if you go with longer stand, you could have some problems with backup.
So we have a Guidezilla. Are you absolutely right?
We will get a Godzilla in.
So Kirti, what we'll do, we'll just watch the balloon expand because then that'll change things if it doesn't, and then we're going to
Perfect.
go to the next, and then we'll come back.
My plan would be simple. I go with an NC at 18 atmospheres, and if I see in expansion, then I would use an IVL.
That's reasonable. Anyone else would do anything different? Would you take now that you've rotated, will you take the NC to 24, 26,
I'll get an NC down, 3.0.
and
try
take it above 18, or what would you take it to?
I would take it to 18 and see how we go. What wire is there down there? Kirti, what wire are you workhorse?
It's just a
This is a
run-through.
run-through.
This is a run-through, my normal run-through.
I mean, for me, I think for cost
Ajit?
efficiency, with laser already used, rota already used, I would try to avoid using the IVL if I could. But the truth is that might be more dangerous to go up to 26 atmospheres or more with an NC. You have a lot of OPN experience. What would you do in this case? Would you use that instead of IVL?
I would.
So I don't use OPN in
definitely, you should go now with 3.0 balloon open and try to open. If you don't have perfect expansion of your balloon, then the next step will be just to use shockwave. I think this is the safest way to approach this case.
And Kirti, you say you don't use the OPN?
If you don't have shockwave, then I would go with OPN. But not so
I don't use
aggressive.
OPN in my lab at all. I took it off the shelf for native coronary arteries. You can see it is at 6 atmospheres and it's completely expanded. You can see it.
That's fine. That's fine. So you can be
Down.
quite sure.
So a lot of the circumferential calciums can break after rotablader down with just NC at a low pressure.
I think important point is also to try to choose a stand with a very good radial forces, just in case you need some more aggressive postulatation.
6-8.
But the balloon
it,
is
10,
opening
down.
perfectly.
It went distal enough, Kirti? It's hard for me to see.
Kirti, is that balloon tracking around that bend?
No, I have.
Okay.
Bend is what I'm worried about. On distal, a little bit more distal.
Yeah,
Stop.
we'll see that.
Down. You want me to show you?
Take the balloon all the way down.
Yeah, just go. Yeah, that was what I was.
Even a bit more distal.
Basically,
We've dilated it there already, but
I
we'll
don't-
do it once more.
I'm not certain it was.
Little more, little more.
I need to be certain that that balloon comes up there nicely before I take the stent.
Because I think that it's right around the bend, and
course.
Yeah.
you want to center the marker on that calcium area.
If you have problems and we see your backup is not perfect,
I think it's still
No, we have
more.
got a
probably
guide
cross.
No,
Other
it's going,
option
it's
will
going,
be
and
to
go, and
take
go, and go.
new
Just
balloon
patience.
a bit
There
shorter.
you go. There you go.
I think we
I
are
think
right in the
patience,
middle.
I think, just sometimes just a
Yeah,
little
go up
patience
there.
and
Let's see this.
go up.
And
go
then
up
we're gonna,
there.
so we're going to see this go up, and then
Go
we're going to go
two.
to the other.
We are just at 2 atmospheres.
2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
It's
nicely
just the bend. It's a bend and a
Okay.
weird thing. That's amazing.
Okay, go down slowly.
I have impression there is a proximal part of the balloon that's not perfectly open.
But the guide extension goes down, so I think you certainly did better. That maneuver is good to see if your stent's going to cross. It's also good in case you have some
Yes.
problem, you can seal it that way.
I think now that it is open, Kirti, I think we'll
me
come
a-
back and show you
What is my
final
length
result
stent?
after stenting.
Yeah, do that.
A few times.
Give me a 28.
Can you connect
yeah,
to
sure.
Dr. Suhas Center, please?
Yeah, sure.
Kirti, we are with you again. You want to show us what you did on the right before going on the
Hi.
left?
So, yeah, you want to show? Yeah, of course.
Can we
of
just
course.
go
Hey, go
back?
back to the right, please. Go back, 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 go back.
Yeah, we
go back.
saw
Yeah.
this.
So we left you here. We saw this. We put the guide extension beyond the lesion where we thought was target, and we then got in our we measured. The reference at the distal level was a little under 3, so I chose 3 as a target, and proximally was around 325 lumen. So I took a 3038. It was a 30 millimeter lesion length. So I took a 38 millimeter stent, and next placed it. Can you see that's the 38 millimeter stent coming in? We withdrew the Guidezilla next, and then deployed it. Next, we took a 3.0 NC balloon, and we went up and targeted inflation. Next. So once we did that, we did an IVUS, and this was our final result.
The distal looks okay.
Show
The
the
distal
IVUS,
looks okay.
MSAs.
Yeah.
Beautiful. I think we don't need to touch it at
We are
all.
not touching
I'm
it.
not going to touch it. And look at the MSAs. The MSAs are 8.37. The next is 6.7. So we did a little higher pressure dilatation here. Next. Our target, believe you me, the target was 7.1. It was a 3 millimeter stent. So we are all 90% in the target areas. This is even more. We got a almost 3.25 here in the proximal segment. So we've decided to go ahead. We've taken a 7 French guide for the, we're just starting the circumflex now. Give me the
So you can see
micro
the
catheter.
angulation.
Yeah.
micro cap.
Yeah, and that is at the distal cap. There was a sharp angle.
Would you guys agree, or would you do anything
No,
different?
this looks
or-
great. This looks great.
Kirti, wonderful job. Beautiful.
I think,
place.
thank you, Ajit. Thank you so much for all you guys over there. I think the 2 points that I wanted to make are, we need to target the lesions that we are going to do before and then stick to a plan, not deviate from a plan. And sometimes metal jacketing these arteries and going into distal arteries may not be worth it unless they are critical lesions. So I think those 2 are important points for me. And IVUS makes our life easy because it really reduces the contrast that we use and takes away the pressure of, having to be in the right ballpark with size and length.
The other trick is the...
Also, we've learned that...
The other trick, Kirti, you showed was that
Yeah.
even when the balloon had a struggle to cross that distal area, the guideline now
You just be patient.
goes through, and its guideline is much
Yeah.
softer than the balloon. And that's something you always see, that the balloon doesn't go,
Yes.
but the guideliner goes with a little bit of balloon support. And that's
Yeah.
a very good trick, so that then your stent doesn't get stuck there.
So now, Kirti,
You
because
remember the other thing I did was, I don't...
Sorry, I was just going to say, because we may have to leave
Sorry,
you
yeah,
relatively
okay.
soon, can you tell us what your strategy with this is? I'm assuming you're going to take a bigger burr, and then to get down into that part of the
So
circ.
I'm going to take a 1.5 burr.
Oh, you're going to take a 1.5, okay.
Yep.
But to get
So
down
the-
into that
so
part
Anil,
of this.
Anil was the... Show me the previous on the circ. So Anil, when he did the rotational atherectomy with a 1.25, he had parked his wire in the distal circumflex.
Got it.
So I am going to change that and go into the OM because I'm going to change my wire bias in this lesion because
Yep.
that itself will help me a huge amount. I believe that will help me a huge amount. And once I do that, my strategy is going to be exactly what I did in the right coronary artery. I'll then do an IVUS, and once I have an IVUS, I'll do a size 1:1 balloon dilatation. If it works, fantastic. Or else I have an IVL waiting for me.
And are you going to atherectomize through the distal left
Any
main,
other
the proximal
suggestions?
circ, or are you going to dynaglide through that? What's going to be your technique for that? You think it will
I never dynaglide into an. I don't dynaglide antegradely into the artery at all. If at all, I will
platform it
just
distally.
platform it right at the left main and go and
Got
do
it.
what I think is right. That's it.
Yep. Same for everybody here? Would anybody dynaglide forward or no?
Yeah.
No.
Yeah, same here.
Yeah. And that's, I think, one of the differences with rota and orbital would be that I think if for orbital, we would actually glide assist through the proximal, perhaps, and then dynaglide, and then go later. So that it's a nice thing to be able to do. But for rota, I think most people platform in the left main and then just atherectomize to move forward if it doesn't push.
We don't have orbital available here. What are the scenarios in
Would
which
you
prefer
try to
that
go
over
to the
regular rota?
larger branch? I think that
Yes, I am
Yeah,
going
we're
to do
gonna
that.
try.
I wanted to get my microcatheter distally and then reshape my wire a little bit. So this is what I do. I do an anti-clockwise on the microcatheter a little bit. And it will slowly negotiate these kind of lesions. But if it doesn't, I'm not going to push it because I'll show you what happens to the tip of the microcatheter when you do that.
Yeah, especially in super calcified lesions, you can leave the tip of the catheter behind. So just be cautious. And for this, you just need to get it to where it needs to go and then make a bigger bend on the wire.
Right.
I have impression your guiding catheter may be a bit too small. We will see.
It's 3 to 5. Let us see.
3.5. I
It's
think.
set perfectly in the LAO view, so I'm okay.
So I think you can appreciate the plaque is pretty eccentric, and so his idea is that if he gets into the OM branch, then the bias of the wire will allow the rotoburr to ablate that side as opposed to the other side, which was what happened.
So, but now the problem is my problem is that my microcatheter won't go beyond this one point.
Yeah, so you just have to bring it back, right?
I think we'll just
Other
use
option
the
will be
other
to
wire.
use some hydrophilic wire, filter XTR like this.
Your problem will be you'll get the wire down, but to get that microcatheter into the other branch will be a little tough, I think.
Exactly.
That was the problem
That is the
even the last
problem.
time.
So here I am. I've got my microcatheter below now. Can you see?
Yeah, yeah.
Yep.
Other option will be to use double lumen microcatheter, will be probably very helpful in this situation.
No, I think I should be okay.
You
there.
should be, yeah, just come back a little bit with it and then just a super massive bend. Yeah, not sure. Run through or something. This is one where oftentimes if you shape it with the tip of the wire
it's fine.
introducer.
No, it's in the proximal
Proximal
one.
wire.
Yeah, if you shape with the tip of the wire introducer with sort of a double bend like a JL
Give me a
bend
torque.
would work.
Take an end wire. Yeah, because last time the wire crossed very easily.
Into the OM?
Yeah, it crossed very easily. I didn't have a challenge in crossing it. I had a challenge in delivering the microcatheter.
So this is the one before.
Yeah. I had a challenge in delivering the microcatheter, but I did not have a challenge in getting the wire down.
The S bend.
We just use a New York wire. They go.
No.
It's an S band, exactly.
Yeah.
Okay, give me a rotor wire, please. I'm going to go ahead with this and then take it on from there. Give me I don't want the same. I want a new rotor wire. Yeah, yeah. A fresh rotor wire. Yeah.
So you're just going to rotoblade on this branch first?
Right. Exactly. Make some room.
I mean, that was the thought I had too when I did not have a challenge entering the OM, but I had a challenge in delivering a microcatheter there.
So what you did worked.
So then I thought that, okay, I can... Yeah, it did work, but we could not get a satisfactory result. And then we thought that, come back and do it another day.
Yeah. And by the way, knowing when to stop in a heavily calcified lesion is also something that takes experience. And so, the fact that you didn't balloon it to then dissect it and shut it down and all of that is super important, because now you can still do the case in a elective setting as opposed to an emergent one.
So from my point of view, you have practically only the chance to cross to the side branch if you use double lumen microcatheter, or you try now with field XTR, or maybe with Gladius. This will be other wire option, or you use supercross angulated microcatheter. But what you could do still is just to rotoblade straight ahead, make a plug modification, and then the next step it will be probably easier to cross to the large side branch, which will be practically the main branch, in fact.
Yeah, I think the challenge with dual lumen or supercross sometimes is that you have to cross through the lesion first to get it, and it may not deliver. But
it's very bulky. It's extremely bulky.
Yeah.
And our experience is not favorable in circumflex lesions.
And especially with these multiple bends,
1.5 burr.
Yeah, I think that's the right thing, is rotoblade this way and then see if you need to rotoblade it the other way.
So that was exactly the thoughts which I had.
Open the push. Yeah. So all I do is I push the wire and my microcatheter comes back.
So you didn't trap it or anything. You just pushed it and it came
No,
out.
I don't. Never do. No, don't.
You did it on fluoro though, right?
So not really. I don't.
I think because you have your own hands.
So typically
that-
just, we try to use, yes.
Yeah,
You can feel things, you know.
So the
as we go
rota
along.
is an exchange length wire. In any case, you don't need to really trap it.
So come along and. So I'll show you what we do, and I'll show you how I do it. I just keep my. You can tell I'm getting old because it's taking longer to thread this.
All of us are. All of us
burr.
are.
But so
We-
Is that,
we
your,
need more
is that a
light.
problem, Ajay, you face as well?
I,
But you have fellows, isn't it?
no, but
yeah, no,
I
got
resolved
my-
that
I got
problem by
progressive
keeping more light
glasses
on the
and I'm
table.
much better now. But so Kirti, tell me again. So this is a short wire.
I make
it's
sure.
a short wire, and you walk the microcatheter out without trapping it. It's a long
It
wire.
was-
Yes,
long
it is a
wire.
normal rotor
long
wire. I mean,
rotor
it's a
wire.
normal wire.
Rotor
It's just a
wire,
normal
that's why
run-through wire. Yeah. No. No. It was a run-through wire on which I just ran through, and then I just removed that and I did my rotor wire.
Yeah.
And
No,
I just push my rotor wire. As my rotor wire goes forward,
See, the rotor wire is 260 centimeters, so it is easy to remove.
Yeah. You have to excuse me. It's 3:30 in the morning in the U.S. So I was confused.
You're brave, man. I had to get up at 3 in the morning to take a flight out to Mumbai today, so I know how it feels.
Ajay, it's awfully nice of you. Yeah, the virus. Okay,
Yeah,
great.
yeah.
So here's the story. So this is what I do.
So this is Kirti's one-man, two-hand technique.
Okay,
So
can
what I
we
do is
zoom-
I
can
have
you-
this on the
Instead
end
of showing
and-
the screen, can we see full screen of Kirti right now? So just show me
Yeah,
full
right now
screen
just
of
focus
him.
here.
All right, so this is
So
he
can you
makes
see
the-
this? My rotor is right here. I have a loop here, which is right above, sitting on me, and I have one hand here holding my Y connector, show that, and I have my other right there, and I'm just guiding my burr inside. So can you see my burr is heading in?
Yep.
And the best part is he
Zoom
does
up
not
there.
even
Don't zoom it.
he does not even do fluoro at this time.
Yep. And no Dynaglide or anything like that.
No.
There's some people who do this step on Dynaglide.
We do the same in our center in Germany. So we go ahead until to aortic arch, and then probably if you have some resistance, then we go with Dyna. But we go ahead without until we feel some.
So look at this.
resistance.
I'm just doing it. I'm just doing a fluoroscopy for your sake, but it's all
show me
steady.
fluoro
You
here.
can see both my hands moving.
Kirti, it's,
There, fluoro, show
it's
fluoro.
fine that you're an experienced operator, but you know somebody who's starting, be very careful.
Yeah,
there will
yeah.
be a loop in the wire in the ascending aorta.
Yeah.
Then,
In the
but the
rotablator,
problem,
that would be a
Ajit, is that
disaster.
when you
That would be a disaster if you have a loop and you don't
sometimes you
see
do
it.
have experienced operators.
So you intermittently just take a peek, maybe.
Okay.
Ready?
Yep.
Okay, let's go. Platform at 180.
Dyna. Yeah.
Platform 180. Okay.
Some jump.
Already you see resistance up there.
So which speed do you have now?
180.
Yeah, that's fine.
185,000 RPM.
So this is nice. Now
I'm still not in the meat of the lesion.
Yeah, he's going to have to advance the system, you know, to re-platform a little bit further back, and so that you need to be experienced in order to know how to do that. Typically, you can either do it on Dynaglide or you can do it while spinning, but when you run out of room.
So I'm doing it while, so you can see my left hand is advancing the system as my right is advancing the burr.
The only downside of doing that is your wire is going to go forward. So if you're worried about that, then what you can do is
No, you hold the shaft.
have an assistant.
If you hold the shaft, your wire is not going to move.
Yeah, I was just saying that. So if you advance the burr with your left hand while you're spinning, then the whole system moves forward because the system is fixed. So if you want to keep the wire in position,
So
the sheath. Yeah, go ahead, Kirti.
So you need to, if you want to keep your wire in position, all you need to do is hold this shaft well, the sheath of the rotor blower.
I think very important point is to use packing technique, not to push too much, because if you push too much, you could have burr stuck, and then there are many curves between, so you could have really huge troubles to remove the burr. And I would go even in this situation, even with 200,000 speed.
So we do that.
We may have to do that.
Go to 200,000 maximum.
But this tortuosity is significant, and that's, I think, the issue that was being experienced.
There's not enough.
And is this the same burr as you used
It's
before on the
advancing
right?
nicely.
Or is it a new
Yeah,
burr?
it's the same burr. It's just 1.5. Yeah.
Yeah.
But we can go up to 300 seconds. At 300 seconds, we would change it.
Yeah. So the idea is that even the diamonds can be abraded.
A
a little
total.
bit.
We have some
It's so
works.
Nickel gets
Ajay,
heated.
We have some
So actually, it doesn't
investigation
the
in
diamonds
Europe.
do nothing? Nothing happens to the diamonds.
Kitty, we have some laboratory investigation for, I think, 70 burrs, which we investigated or tested under electroscopy. And,
SEM.
yeah, and we didn't observe diamond
You did not,
damage.
okay.
So it's very stable.
So diamond, nothing happens to the diamond. But tomorrow I'm going to give a talk, and I'm going to show you that the tip is nickel, and because of the heat,
That
the
gets
tip which is
roughed up.
conical over a period of time, completely it kind of opens up like a flower, and
Yeah.
then the ablation, the ablative surface does not touch. That's how the
Yeah,
burr
yeah,
fails.
yeah.
But you need a soft metal because otherwise it'll burn the wire.
You need a what? Say that again.
So you could put in a very heavy metal like a platinum, and that would not do that because the circumferential spin, it's like pottery, it just opens up. But if you use a very strong metal that doesn't do that, then one of the metals will yield, and so the second metal is a wire will yield because it's stainless steel. So they had to have a softer metal than stainless steel so that it'll give way.
Got it. But the point is that, I misspoke. It's not the diamonds get messed up, but you lose your ability to advance. So sometimes switching
The
to
burr
burr
shape.
later makes sense.
The burr shape goes.
So Kirti, just if your bird doesn't cross now, what is your next step? Would you take an extra support rotor wire or downsize your rotor?
No, I'll just be patient. It'll cross. It'll cross. So we just have to be patient. The patient's stable. The right cornea is opened up. He's tolerating the procedure well. We are at 230 seconds. So very shortly, I'll change the burr to a new burr, or take a new 1.5 burr. Or that time, I could even take a 1.25. That's okay.
Yeah. So Kirti, your time
I would,
limit is...
I would recommend you to use 1.25 if you have problems with 1.5.
So you're...
I don't have a problem. It just is going to take a little longer.
And you do 300 seconds before you replace the burr, is that right?
Yeah, because we looked at we took photographs of the tip of the burr, and we realized that all the burrs which were less than 300 milliseconds, nothing happens. It's only when we do long ablations in tortuosities that this whole thing opens up. I'll show you some high resolution photographs tomorrow if I can.
Yeah. I personally would be a little reluctant to use a 125 in this case because it's this tubular lesion.
Yeah, I'll get
It's
started.
big.
I think
You're primed for burr entrapment in a case like this.
So it's really very hard. This is, I think, the attempt number 7 to cross, and
I think it's attempt number 17. Because I have also made attempts before this.
Yeah, and I might go up to 200 as well.
yes, go to maximum speed. I think this will be the next step.
So the problem is sometimes when the rotational atherectomy catheter takes more than one bend, it will not allow you to exceed 190 because of just the way the pressure works. It doesn't go up on high speed.
I'm not sure.
So we are on maximum. We have turned it up to maximum. Give me another burr, 1.5.
So new.
So we've
burr
gone to
will go.
343. So we're going to change the burr. Yeah, yeah.
All right, so we're going to go back to Pune because they're ready, and we
Go
fully
ahead,
expect
go ahead,
your
and we'll
first
let you
run to
know.
cross with the new burr.
I hope.
Yeah, Kirti, we are back with you. We can stay with you for 5 minutes and then
Okay,
need
that's
to
our
break.
new burr.
This is a new 1.5 burr. Yeah, I think there is a little movement this time.
What new,
We can
new
see it
1.5
entering
burr.
the lesion because that's the bend.
So we're fluoroscopically, it looks like a little further than where I was before. Marginally.
It looked like maybe a little bit further, but
Yeah, it did. But you know, you could be wrong.
Yeah, yes.
yes.
Be careful.
Don't stop behind the
Stop.
lesion. And this is exactly the point. You have
Yeah.
always to come back, and this is exactly. Take care with your guiding because you could dissect left main.
I will.
Stop.
I will.
Stop. Be careful
Okay.
because
Give me
now
a-
you could have problems.
Give me a cut, give me a guidezilla. Give me a guidezilla.
So
Take
Kirti,
second wire, take small balloon, and then make further
one thing,
rotation.
Kirti, I might try because it's really so close there.
Has the
Is just pull back on the wire. You may be able to dislodge it by just pulling back on the wire because the weld will pull it back. Now, obviously, see how
It's okay.
close it is?
Give me a.
Just pull straight back on the wire. Don't spin. If you pull the wire back, you engage the weld on the tip, and it will often come
My
out.
problem is I want to do it with the guidezilla. I want to do it with the guidezilla.
That's fine.
My suggestion will be to go a bit deeper with a burr, to take second wire, and to make with 1.5 a bit space.
Give me a
Okay.
cut. Give me a
Scissors.
cut. Give me a
Mobilize.
scissors or a
Scissor.
shear.
I think this is the safest way. If you try to remove the wire, you can lose really position. You can
Give me a
have
guidezilla.
You
huge.
do it with the guidezilla. I agree. So he'll cut, he'll take the guidezilla down,
Yeah,
and then
this is better.
and then see. So
Give me the guidezilla.
I think Kirti can work in peace. We'll break for lunch and then we'll come back, or you want us to continue?
Come back,
No,
come
you may
back.
like to watch this.
Yeah, I think this is very important to see.
let
This is
him
one of the
decide.
unusual problems that you see in rollerblader, which, Kirti is pretty experienced. He'll get out of this very nicely. Let's see how he does this.
No, it's up to you, Kirti. You want you will break and come back, or you want us to continue? It's up
Yeah,
to you.
you can be there. You can just
Yeah,
be
so
there.
this is
Okay,
perfect.
no problem.
You can be
Whatever
there.
you say. No problem.
So what he did is he cut the back. He has
Okay,
the guide
okay.
extension down, and now he can hopefully pull traction with the wire and the guidezilla. And if So he's pulling hard on the wire and it's still stuck with the guidezilla there with full traction. So at this point, he's going to have to use other maneuvers if this doesn't come out.
We'll dissect everything. We'll take another balloon.
Okay.
Wire.
Give me another wire.
Give another wire.
Okay, so Kirti, I would suggest another wire.
Another wire and free.
Yeah,
it.
we're doing
Take-
that. We're
take
taking we're taking another
1.5
wire.
balloon and you can
one-
mobilize
one-
the burr. This is the safest
And-
way. Because otherwise you could even make huge dissection or even perforation in the ostial circ.
So what we'll
You want to
do,
take an in wire?
Yeah, no,
I-
this is good.
You have
Give
a
me-
Sean black?
yeah.
okay.
Give me a microcatheter.
Yeah, so good idea, go microcatheter, have good control, reshape. You can potentially get that passed.
And give me a UB3. Give me a UB3.
You want to take a UB3 or a Sean
Yeah,
black?
UB3.
Yeah. Where is the microcatheter?
Right there.
I can't. Okay.
Can you see that?
Yeah, yeah. Yeah, fine.
Okay, come on. Now give me a
UB3.
Give me a torquer. Give me a torquer.
So I think go ahead with a microcatheter to the burr, and then probably you need to use some CTO wire, and then to have.
Exactly.
Yeah, yeah, we're
Yeah.
doing that.
So what's the wire using, Kirti?
So I'm going to go with a UB3.
Yeah, the issue at this point is that the burr is caught in the tightest part of the lesion. I was talking to Miroslav here, and the reason that he had said to move it forward a little bit was to make room for the wire to be able to cross through in that segment.
Torquer.
Talker. No space.
I think we'll go to Pune once, and then if you want us, we'll come back, Kirti. Can you switch to Suhas Pune?
Perfect.